Good afternoon, everyone. It looks like we have a good number of people on the line now. So this is Laura Beamish speaking. Thanks so much for joining us for our sixth coaching call of the Boost Collaborative. We're really excited about the webinar we have for you guys today. So we have two speakers today. I'll let them introduce themselves to start, and I'll just hand it over to Tina now.
Okay. My name is Tina Shaw. I'm a peer supervisor at the Molson and the Maple overdose prevention sites. PHS has always been the pioneer when it comes to viewing people who use drugs as well people. This was unheard of at one time, and the approach taken by PHS was and continues to be revolutionary. And as oppressive as I personally feel the label peer is, I use it today because this, unfortunately, is the designation one must use if they refuse to lie about their drug use on their resume, although I don't see why it's anyone's business what one does in their private life. But even today, I still see services provided by not only PHS, but by every service provider in the downtown east side, where they are not utilizing the expertise that can only be provided by a peer. And I see service providers who are losing out because of this. I believe that, and I'm totally biased when I say this, we have far surpassed all expectations of what a peer is capable of achieving with first the Maple, then the Molson overdose prevention sites. We have made ourselves invaluable during this crisis, and I also believe that we've only just begun to see the many benefits of hiring peers in the downtown east side. First, the benefits to you, the service provider. By having peers work in all different positions, spanning the wide array of different services you provide for the people who've come to make the downtown east side their community, their home, I believe that the multi-tiered employment model developed by the former staff at the now closed Drug Users Resource Center would work incredibly well in any organization whose mission is aimed at helping the marginalized population that makes the downtown east side what it is today. Peers with all different levels of functionality could benefit from working at the different organizations. For instance, and here I will use the levels outlined in the Vancouver Coastal Health Peer Handbook for the examples. Level 1 peers who have limited attention spans and cannot be relied upon to keep scheduled shifts can come between certain times to complete individual tasks that are not urgent but need to be done daily, such as the mopping of floors, cleaning washrooms, or the windows. And these tasks can be paid by stipends given to the peer upon completion of the task. Tasks that take up time for staff and take them away from the more important aspects of their job, yet need to be done to maintain the functionality of each space. There's always something else that gets pushed aside for the next shift, next day, or even pushed aside until further notice because of the routine housekeeping tasks that must be done. At emergency shelters or community centers that exist as a resource to our ever-growing homeless population, level 2 peers can be an incredible asset. Because let's be honest here and say that 99.999% of peers have been homeless themselves once, twice, or possibly 50 times. The knowledge of exactly how it feels when you're homeless is something that can never be adequately experienced through reading a book, no matter how talented the author. And to have someone with that expertise there to answer phones, hand out snacks, or even just as an emotional support for the participants would be beneficial. The conversations between the peer and someone who's at the lowest point in their life, who's being told what to do and when to do it by everyone who's supposed to be supportive, yet comes across as stern and unyielding when enforcing rules. The rules that the client doesn't see any logic behind can be explained to the client by the peer using language that, although foreign to you, is exactly what will resonate with the client, ensuring compliance and willingness to follow rules that ensure everyone's safety. Conversations would be honest and meaningful to the resident or client. I guarantee it, because they would be authentic and they would impact their lives to see someone who's been where they are and got out. No matter what that looks like, it's a step above where they are at, and that creates hope. As well, when dealing with shelter residents or our homeless clientele, I believe the peers would handle situations with an empathy that is unique to people who have lived with the troubles and obstacles that are so common to people who are struggling just to survive day by day. Overall, I believe that there should be no limit, no constraints when it comes to what a peer should strive to achieve in the employment structure of any service provider. Because not only do they have a unique perspective when it comes to things that have a direct impact in their lives, but they alone can show any service provider where things aren't working as well as they could be. And chances are they will have already thought up countless solutions because they know what didn't work for them and what would have. One of the great benefits for peers is the knowledge that there's a chance with hard work and dedication, there's nothing they can't do. Maybe one day they too will become a supervisor, a coordinator, or even a manager. And even for the level 1 peer who's cleaning the bathrooms for a stipend, they can have their hard work and dedication to performing a job well done acknowledged by their superior, and they can be given a promotion. Maybe that looks like their boss giving them the first opportunity to pick the job of their choice the next day. Or it could be a gift card for an extra $5 after they consistently show up to do the assigned task within a shorter time frame. Everyone, regardless of whether you are considered a peer or not, likes to be recognized for a job well done. The level 1 peer will probably never be able to adhere to a schedule or even a prolonged shift, but they will work so hard for the hour it takes to clean a washroom or the time it takes to make windows streak-free and sparkling if it means a bit of extra money that they didn't have to steal or sell their body for. They didn't end the day in handcuffs in the backseat of a cop car, and they didn't end up in handcuffs in the backseat of a John's car. But they did have the freedom to show up or not, or come in a little late because they slept in. And they could do a quick job when they were able to, and when done, they had the same pride associated with any job well done. Then, guaranteed, they take their stipend and go and search for the substance that they've been obsessing about for that hour that felt like a day, without having to spend the full day that would have felt like a week in order to get paid. It's the immediate gratification that their whole world is centered around. Here's the part I witness most often. As a self-identified peer, as well as the highest level peer according to my boss, I've worked hard my entire life to be self-sufficient, once upon a time to support my very pricey cocaine addiction. And to do that, I learned to hide my addiction behind articulate words, an immaculate wardrobe, and hard work. And I did it well because never did any of my employers ever realize that I had a $200,000 a year cocaine habit for 17 years. I graduated college with honors while working full-time at night in a strip bar. I successfully ran my own upscale residential cleaning company for years after I graduated, and never once in all my years of being entrusted with the keys to million-dollar homes did I ever come under scrutiny for drug use or theft. I self-identify as a peer because it was only after over 10 years of unconditional love without judgment, even when I was unlovable, that I even realized I was worthy of love and decided to choose life. The opposite of addiction is not abstinence, it's connection, and I think that everyone deserves the chance to heal. Unfortunately, with this epidemic, so many will never get that chance. So as a peer supervisor at PHS's overdose prevention sites, I get to become for others that source of unconditional love without judgment that was so pivotal in my life, so that they too can live to choose life. The sense of purpose that a level 3 peer, who for all intents and purposes is unemployable, gets when as a client they start their first day at MOPS is undeniably one of the best things I get to witness. Not having to worry about trying desperately to hide their need for drugs. Not worried about every day that the withdrawal that inevitably comes when forced to go 8 hours without what is as much a necessity as the air they breathe. The sense that comes with pure relief, knowing that their drug use is not going to interfere with their duties to the point of losing yet another job. It's incredible. It's amazing to witness the transformation when I tell a client that they can work at MOPS if they really want to. But it's going to take some really hard work. It's going to take determination and reliability because it's a process. They have to earn a place at MOPS. They have to start out at our Spikes on Bikes program, and if they work really hard, are reliable and consistent, and show that they have what it takes, they qualify for a training shift at MOPS. Then it's up to them how far they want to go, because there they have to start all over again from the bottom, fishing shifts, and learning everything they can by watching those who have been there and get to know the ropes by being reliable and consistent. And they want to become part of the solution to this crisis. And with their hard work, they will be acknowledged, and they can go as far with this job as they want to take it. They can stay on as a stipend floor attendant, or they can go the route I went, which was to get on payroll, then apply for a supervisor position. They know that how far they go is totally up to them. They have control in their life to actively shape their destiny. And they don't have to give up drugs to work there. In fact, quite the opposite. They can do a shot before work to ensure they won't suffer, as long as the privilege isn't abused, and keeping in mind that people put their trust and their lives in our hands daily. They can come to work, do their shot, or leave to get their methadose without fear of reprisal, and it changes them profoundly. All of a sudden, they have opportunity. They have something to work towards. They can achieve goals, which has a side benefit by releasing the same chemicals in the brain that achieve the high they are used to only getting when they use drugs. Only now they're producing them naturally. They have meaning and purpose and connection. And I see the proof every day when peers who began as clients are using less drugs daily. They discipline themselves to achieve their goals. They show empathy and kindness instead of the all too familiar street mentality of someone who's been beat down and has no reason to care about anything but the high that consumes every waking moment. The most prevalent thing that I've witnessed is someone who began as a client, who I personally would consistently intervene to reverse multiple overdoses monthly, sometimes weekly, is now a coworker who hasn't overdosed once in over 3 months. And best of all, we are pioneers, starting something that will be forever looked upon for its innovative, fresh approach to solving this crisis by radical kindness and unconditional love without judgment. And one last word, as peers are extremely underutilized, they are also extremely undervalued. I challenge you when hiring peers to set the bar high. Show the people who have for so long been marginalized, criminalized, and vilified that their life, their expertise is invaluable to you because they are an integral part of helping you achieve your goals of being the long sought after solution that will not only keep people from dying of fentanyl poisoning, but to actually heal the negative effects left by the failed war on drug users. I mean, let's face it, we all know when someone fresh from university, with all their degrees and their good intentions, comes to the downtown east side raring to fix us, as if we are the problem, instead of being the result of the problem. Drugs and alcohol are not the issue. How we treat one another is. Thank you very much for allowing me this platform to speak on behalf of myself and my fellow peers, who are the true experts, and who I believe will ultimately be responsible for finding the solution to finally bring an end to this tragic crisis of epic proportion.
Thank you so much, Tina. So if anyone has any questions, I'm just going to pop back to this slide. So in your control panel that's just on the right of your screen, you can chat in questions, or alternatively, you can put your hand up with that little hand icon, and we can unmute you and you can ask a question. So if anyone has any questions that they'd like to ask Tina, we will maybe give a couple of minutes here, or you can chat them in as well, and I can read them out for you if that's easier. So we'll just give it a minute. We can also maybe provide some contact info afterwards if people have follow-up questions. Yeah, great. Okay. So if you guys have more questions that they come to at the end, we'll have some time at the end of this hour also for questions. So feel free to type them in as we go here. And so I'm going to hand it over now to Belinda. Great. I'll let Belinda introduce herself.
Thanks so much, Laura. Hi, it's Belinda Boyd, and I'm with Vancouver Coastal Health with community engagement. And I'm going to tell you a little bit about community engagement, how it began, and what it is that we do. And I just want to say thanks to Tina. That was very powerful. And I'm going to hear about how we hopefully make that manifest within our organization. So is it just this one? So what is community engagement? So community engagement, we believe it enables that two-way interaction process between Vancouver Coastal Health and its communities, so that communities have a key role in planning and decision-making for health services and policies that affect their lives. So that's really it in a nutshell. So the community engagement team or department of Vancouver Coastal Health has been in place since 2001, actually since the inception of the health authorities. And it has a really interesting history, one that we're very pleased and proud of, is that before the formation of the health authorities, there were health boards. And if you've lived in the province for more than probably 20 years, you might remember that structure. But in those days, they had people who lived and worked and sought services in their communities were involved in what they called population health advisory committees that advised those boards and had a lot of influence about how healthcare was planned for and delivered into their communities. So when the structure changed and the government of the day decided to create these Uber health authorities, there was a bit of angst around, well, where's that voice? How are we going to have a direct connection to our communities and have that voice reflected in our healthcare planning? So luckily, those people advocated for some continuation of this mechanism. So hence how community engagement came to be at Vancouver Coastal Health. And we still are the only health authority that has that kind of formalized department. And because of that, VCH is recognized as a leader in community engagement and patient public engagement. So we also noticed over the last few years, there's been a real groundswell of support for patient public engagement, and it's just growing, I think, exponentially. So when should we do community engagement? So there are lots of reasons, but these are some of the reasons. Whenever we have a decision to make, we look to pull the feedback and input from those who are most impacted by that decision. And that's what always should drive engagement, is who is it that we need to connect with? Or if we have a question to answer, a problem to solve, an opportunity to look at, a relationship to build, a history to heal, those are all examples of when we would seek to do community engagement. Why do we involve clients and families in decision making? Because we do believe that we make better decisions when we do speak to those who are impacted by those decisions, whether it be mothers and fathers and families, whether it be peers, people who are using our services. We just finished doing a round of focus groups to support the development and planning for a new withdrawal management center that's going to be opening up in a few years. So we know that as a health authority, that when we reach out and we engage with those who are impacted by our decisions, we make better decisions. And that's leadership. That's really what leadership should be, is engaging with people. So just so you know, we do a lot of evaluation on the work that we do. So from the perspective of staff, we ask them, like, how does community engagement help you to achieve? And you can just see by this, you know, improve relationships with stakeholders. Definitely, it impacts the trust and the relationships that we have with those in our communities. People know that it certainly creates better resources or services for patients and clients when we go out and we speak with them. We provide learning that we would not otherwise have discovered. For us, certainly every time we do a process, the staff who are involved, the leaders who are involved say, that was incredible, I didn't know that, or I learned something that I didn't know, and it's certainly going to support me in my decisions as a leader. Definitely we have more credibility, I like to think. When people come, they participate in processes, we definitely get that feedback, you know, that this was, wow, this was great, can I do more of this? This is, you know, to be able to have that voice certainly raises the credibility and the trust for the organization. And they strengthen the team's capacity as well to further patient engagement. We do a lot of capacity building. We have a very tiny team in Vancouver Coastal, so we do a lot of training and support and mentoring, because we believe that everyone should be doing engagement. It's not just ours to do. So yeah, definitely it has an impact, as you can see by what staff say. And also, as I said earlier, it gives you that social license and that ability as an organization. We have a mandate, and every time we go out and we have a dialogue or we engage with people, we're better able to share what that mandate is and what it is that we're required through legislation to deliver. So in that interaction, we're able to share what we need to do, but in the engagement, we learn how to do it together, and we learn how to, you know, make better decisions as far as how we do it. And that builds, as I said, that social license and that ability to be able to make those changes. Because in healthcare, the decisions are only getting harder. So why, if you were a leader of an organization, would you want to make those decisions all on your own? Certainly you'd want to talk with people. And people will support what they've helped build. You know, you see that. I mean, it's in any kind of a relationship, anything that you do. And we know what happens when it's the opposite. If you don't engage people, I mean, certainly everyone has probably seen some example of what happens when somebody does not, you know, agree, or they have a difference of opinion and they can't get to consensus, or they can't get to a decision. So And the other thing that's really, I think, relevant when you look at healthcare is that the social determinants of health, self-determination is a powerful determinant of health. So for us as a health authority, if we're not providing a mechanism for people to have input into not just their own health care, but also from a systems perspective, how we guide and determine and make decisions, we actually don't allow people to have that ability for self-determination. And you could say from a health authority's perspective, that could almost be considered unethical because you would be denying them that ability to have a better health outcome. So our drivers for patient public engagement, it's interesting to me that if you think about other areas of the way that our society works, there's mandates and legislation for engagement in most other sectors. So if you think of local government, provincial or federal, they have mandates around engagement. If you think about energy or mining or forestry, things that go in the ground, in the air, on the water, we have to do engagement. Actually, there's no legislation around engagement in healthcare, so it's a choice that we make, but it drives quality in care. Definitely people have expectations around it. I think generationally, we're seeing a shift in what people want to participate and having that discourse, that public discourse around issues related. And, you know, as Steve pointed out, we have big issues related to healthcare as it relates to substance use, and we need to dialogue on those to get to a place where we can all get better and be better. So, and we also are seeing more and more government movement on it, and more of a requirement. So when the ministry comes to health authorities and they will say things to us like, we want to understand or have you develop a different model of caring for this particular population, but you will do that. You will develop that model in consultation with that population, and money is sometimes attached to that. So there's drivers that are definitely in place for encouraging health authorities to do more patient engagement. And we also believe that person and family centered care, which is a term that we hear a lot now in healthcare, is an outcome of engagement. How can you say that something is person and family centered care if you have if you have actually not spoken to the person who the care is being provided to? It's kind of one of those direct correlations, you know. It's person and family centered care comes from engagement and understanding what it is that people need. And we believe that we definitely impact that when we do engagement, and we create mechanisms for embedding person and family centered care. These are our guiding principles within our team. This is what guides the work that we do. I won't go through every one of them, but you can see it. And I think, Lori, you do send out the slides, you do include them. So these are what, as I say, guide and sort of underpin our work. Definitely, as I said, you know, bringing diverse voices, targeting the engagement to those who are impacted or affected by it are key. And another one I would say is how that our transparency, and really highlight that, because when we engage, when teams come to us and ask us to support them in an engagement process, we are very clear that all the information that we gather goes right back to the people that we engage with. So they're all part of that whole process. So the benefits of engagement are many. Here are just a few, but again, value to the participants, certainly being engaged in a system that supports their health. And I think one thing that really resonates for staff, I think generally, is that people that are are receiving healthcare, they're not just the recipients of care, they're also the payers of the system. So they have an investment, and they are, you know, they're interested in being involved. As evidenced, and I'll share with you some about our advisory network, which is a very robust network of people. So we see evidence of people wanting to be engaged. It certainly, as I said earlier, improves the understanding of issues. We have so many limitations as to what we have to provide within healthcare around the legislation, but also some of the processes. Like even when you go out for RFP, like it can seem very complex, and it is complex. So every time we can engage with people, we have opportunities to share more information so that there's an equal understanding of what it is that we're both having to work towards to be able to achieve an outcome. So, and then from the healthcare providers, certainly we hear from people that, that work in healthcare when they are involved in an engagement process, they learn how to provide care from a person-centered perspective. It increases their awareness of what the barriers are, and it definitely increases job satisfaction. People want to work for an organization that aligns with their personal values, and it's something that I think resonates with most people, wanting to hear and listen to people and engage with people. And then from the organization perspective, everyone knows that money is limited. We already, as a health entity, all of healthcare takes almost 50% of our entire provincial revenue. The government has said that's it, like no more, because as a society, if we put more into health, then we take it away from the arts, we take it away from education. So we need to have that balance. So if we're going to target resources, why wouldn't we engage with people to make sure we're using our resources effectively? Because why would we want to waste dollars? And also bringing those diverse perspectives, and it strengthens those community relations. We're just a better organization from doing engagement. So a little bit about how we involve them. So there's three sort of key areas, we call them domains, around patient-public involvement. So the first one is where patients, clients, and families are considered partners in their own care, where you're really engaging them. And this really speaks to that self-determination as well, being able to have a real role and being part of a team, part of the team in your own healthcare. And then obviously, being able to be responsive and patient-centered. And then there's patients and clients as the prime focus of care. And how this works is, and I'm sure most people who are on the call, and if they're doing any quality work, we collect a ton of data in healthcare. We know everything. We know when you came in. We know when you went out. We know if you caught something when you were in. We know if you fell when you were in. We know, we have a lot of data. So sometimes engagement can be looking at that data that's generated by our patients and our clients through our interactions to be able to understand how to improve that patient experience. And then where community engagement really puts most of our focus and energy is around the public and community participation in shaping the system and looking at the bigger, broader issues and engaging ongoing, looking at how do we deliver care, how do we design our programs, how do we design our facilities, how do we make them patient friendly. So that's where we primarily focus our work. So we are affiliated with the IEP2. And again, this is where, when I mentioned about the mandates and legislation around engagement, most of our colleagues that are with IEP2 work in those other sectors. Health is actually a small component of people working in engagement, but this is their spectrum. It comes from the IEP2, and it reflects how we engage people along that spectrum. And it's not that any one level of the spectrum is better, or it's just that it has an increasing level of influence. So, and we do all of these. So you can see at the bottom where it says, so inform, it's basically the promise to the public is we will keep you informed. And that's what we do through mechanisms like our website. But as you move up, consult, involve, you're starting to engage with people at a level to say, we really are seeking your input to help guide our decisions, to understand how we can move forward, make this better, or create this new program, or build this new space so that it reflects your needs. At the collaborate level, that's when we start to move into a more shared decision-making model. So we have a number of advisory committees, reference groups in which we have shared decision-making. And within Vancouver Coastal Health, there's probably only one area that I would say it really captures that empower level, and that would be our SMART Fund, where VCH is really just the holder of the dollars and says to the community, you know what's best for your community, you know what you need, we'll just funnel the dollars and you decide and you implement those decisions. So we also, in addition, I touched on our Community Engagement Advisory Network. And our network, we have a 300 strong network of advisors. I like to say they're in relationship with us for the purpose of making healthcare better, because that is really their goal. And we employ them in a lot of ways. They support us in so many ways throughout the organization. One is they do interviewing of our staff. And again, if you want an organization that is patient and client centered, have patients and clients interviewing the leadership in your organization, because that definitely has an impact on the type of people you hire. And it's so interesting because we have one of our directors that I know of had members on her panel now does not hire anybody without having advisors on her panel. She was so impressed, and she came and worked for us, came in from another health entity in the country, and just speaks to how impressed she was that advisor was there as part of her interviewing panel. So this is the network I spoke about, the Community Engagement Advisory Network. We always say they're keen to help, and they are. It's a little old, I should have updated it, but we're almost 300 now. People who live, work, and seek services. They were created in July of 2009, supported by our team. They receive orientation on being an advisor, and they sign off on both our confidentiality and respectful behavior undertakings that we have, the same ones that staff sign off on. So there's just a quote from a network member. We work very diligently to ensure that the placements are meaningful, that the involvement of our network advisors are that the staff have a readiness for advisors to be on those projects or committees, and that advisors are seeing the impact and the value of them being involved. So from a support perspective, we have a number of ways that we can support, as if you're seeking engagement, either wanting community engagement to do a specific engagement process with a clientele or a cohort of individuals, or if you're looking for an advisor, the mechanism is the same. You make a request, and then we support you to place an advisor in that role. So if you go to the website, I'm not sure if everyone has access to VCH Connect on this call. If they don't, they can certainly contact the community engagement team. There's our email and our phone number, and we can provide you with all the tools that you see listed there and more. Just to run down, I might have just a couple more minutes. Yeah. So we have we've created a booklet for how to engage with patient public advisors for staff. So it literally walks you through every step of how do you create readiness for having an advisor. Sometimes that's an area of concern and angst for staff, because they're like, oh, if we bring somebody who is not a staff and they see all our, it's like showing someone your underwear. I don't know. It's like, they're going to see something, or they're going to find out something about us. Like, we're not as organized as we people think we are, or whatever. And we're like, that's okay. Like, it's getting through that initial, I don't know, I won't say fear. It's not really fear. It's more like just an angst about, are we ready? Can we engage? Have we got to a place where this is a good thing? And we always say, do it as early as possible, engage as early as possible, and everyone who's done it, the angst, it's like a thing of the past. They don't remember that was something they even were concerned about. So that booklet really helps guide them through that and gives them a sense of confidence. The Patient Public Advisors 101 is just a succinct kind of excerpt from that people can read. An advisory committee workbook, if you're considering, we have a lot of staff who want an advisory, especially within our mental health and substance use departments, where they want family or client advisory committees. It literally walks you through, like, how would you decide on the makeup of the group? How many clients or how many families or family members? Sample terms of reference, sample agendas. So it's a very sort of rigorous tool for people to be able to kind of walk them through and feel confident. The fact sheet on patient and family-centered care, if you're looking to convince somebody, maybe you need to take that up to a supervisor, or you need to talk with people about, we think we should be doing this type of engagement, and here's some reasons why. That's a good tool for that. And then that interview tool that I showed you earlier, if you're looking for, even if you don't have the ability to have an advisor on a panel, the tool has questions on it that direct the conversation towards how do we make our services more patient and family centered. So the questions are there as well, and they were all developed in conjunction with our advisory network. So you know that. And then the Keen network that I talked about, they also review documents. So they'll look at patient materials or brochures or anything that we're giving to patients. They will review for readability, for usability, for patient friendliness, and be able to provide input. So so we have a raft of tools. As I said, we've been doing this for a while. We like to say we're easy and we're cheap. We give them all away. we don't hold any. We just ask if you adapt anything, and we've had requests for materials. I think we just had one the other day from the Philippines, and from Nicaragua, and like different places. Like people ask, because people in some areas, this is an evolving thing. This is new, but we've had the benefit of being able to do this for a while. So we have a lot of these tools, and we're here and available to you if you have questions. So I'll stop there.
Great, perfect. So no questions came through while either of our presenters were speaking, and so maybe I'll see if there's any questions now, or even if some of our folks who are on the line have even just anecdotes from their experience involving peers in their clinics, or any challenges you face, anything sort of add or contribute to the conversation. So you can either, maybe I'll pop this screen back up. So yeah, you guys could either put up your hands or chat in any questions. Everyone's quiet today. Oh, there's Amber. So Amber, I'm gonna unmute you and you can ask your question. Just one sec here. Okay, go ahead, Amber. Sorry, Amber. One sec. I'm gonna do it on this computer. Okay, go ahead, Amber. We're having some slight technical difficulties. Amber, maybe could you chat your question in? We're just having a slow moving computer on our end. Amber is on our advisory committee in a peer role, so I'm hoping that we can get her question. Okay, Amber, do you want to try again?
Okay.
Yeah, now we can hear you.
Okay. Sorry.
No, that was us on our end, technical difficulties.
Okay. Well, I just wanted to say that being involved with the Downtown East Side second generation strategy and doing the advisory committee and stuff and being involved with this has been really wonderful to actually get to have my input and see the response from people, how people are interested, that are working in the field, are interested in what I have to say, and actually value the experience that I bring to the table. And it just working in peer work for as long as I have has made such a huge impact on my quality of life. Like, I came from a pretty down and out life, or whatever, like a rough childhood in the system and all that, and I've turned my life around. I've been raising my son for 11 years, and all the while it all started with being involved in you know, peer groups and doing engagement and work like with the healthcare system, and being proactive. It was really empowering for me, and so, you know, the drug use isn't even gone, but I'm super high functioning, and it's not like the primary focus of my life, right? And so, and being treated with dignity and as a valued member of the team, regardless of my personal choices of substance use, and has given me, like, you know, self-empowerment, and has given me the confidence and the drive to do better in my life. So I just wanted to stress how invaluable it is for peers when they get, you know, to be treated well and given the opportunity to do well and show that they can, you know, make improvements in their life in other areas without having to stop the substance use first. And that's just this huge benefit for creating better communities and helping actually really get to the root of the issues of the substance use and the overdose crisis. So thanks.
Yeah, thank you. So I'm just gonna switch the sound over so it's better. Thank you so much, Amber. Just bear with me one sec here.
Thanks, Amber. I just wanted to comment. It's Belinda. Hi, Amber. So thanks so much for your comments, and I wanted to say how much I'm looking forward to as well having you participate. I didn't mention, but the Keen members, we bring them together usually a couple of times a year, but this Saturday we're all dialoguing together because VCH is looking at its values. We're looking at how do we define ourselves as an organization and reflecting on that, but also redoing our values. And we're going into dialogue, our leadership, with the Keen members. And I know Amber's going to be there, so I'm looking forward to that. So as she said, you know, bringing diverse voices and experiences together make us better as an organization.
We just had one question come through, and I'm just hoping that person who chatted it in can clarify it. The question is, how do you balance your own experience with the pressures of daily work? And I'm just not sure who that question's for. Maybe for
As a peer, yeah.
Yeah.
So I spent 4 years of my life actively healing all of my childhood traumas, all of the false belief systems. And it really did wonders. When you heal the trauma, the psychological aspect of addiction goes away. And as I don't get triggered at work, what I do have is an opportunity every day to give others hope for healing. And nobody is ever going to choose life if they don't feel worthy of love. The only time that you will ever realize they're worthy of love is actually when they're loved. So I just look at every day as an opportunity to show our most vulnerable, our most outcast, marginalized members of society. I get to love them. And some of them have spent their whole lives without that. It's an amazing privilege. So I don't actually even look at it as a job. I look at it as a privilege.
So there's one more question here that asks, so peer navigators have lived experience that in some cases is resolved. What do you do to reduce the risk of relapsing?
Don't stop using drugs. No, you know what? A vacation on a beach with nonstop pina coladas. No, that was just like a little dig for my bosses. But, I find writing for me, anything that relaxes you, anything that's creative, and Epsom salt baths. But writing for me is my outlet. After a really hard day or lots of overdoses, I'll just go sit at Crab Park and I'll just write. And that is the best outlet for me, is just to put my passion where it's going to make a difference.
So we still have a few more minutes. If anyone has any other questions, if you prefer to put your hand up and ask a question live. Okay, there's one more here. So we have a question from one of the nurses who works at Three Bridges, and she's asking, what's the first step for peers that wish to get involved? So I guess I could go to either. Maybe start with you.
So with Portland Hotel Society, every Tuesday morning there's a job meeting for Spikes on Bikes program, which is the entry level position that you get to become a peer employee, and that's at alley outreach, riding bikes through the alleys, handing out harm reduction supply, intervening in overdoses, and engaging. And then when you've done that for a little while, then you can come in and have a training shift with one of the supervisors at the Maple or the Molson overdose prevention sites. And then it's just a matter of showing up and getting shifts.
And for us, from a peer perspective, if people want to join Keen, they can certainly. We do have a peer reference group. It's in a bit of a hiatus now, but there are lots of opportunities that present themselves. The way our intake works is we get requests that come through from various teams throughout the health authority, and then we compile the outline, or the sort of what they're looking for, the time frame, what the commitment would be, and then we put it out there, and then anybody from Keen can respond if they meet that criteria. And if it's people who identify as peers, they can, we do provide some remuneration or honoraria for participation in those processes. And we welcome them, for sure. It's great.
Great. Any final questions out there from anyone on the line? So as was mentioned, we'll be posting this recording online, and then we'll also have contact info if people want to follow up or have questions. Definitely, if questions come up and you want more info, don't hesitate to email, and we'll make sure we pass that along.
Excellent.
Great. So thank you so much,
Thank you.
everyone, for coming.
Thank you.
Thanks, Dr. Benjamin.